in 2017, at this point, in patients who have metastatic colorectal cancer, as this patient does, there probably is really no specific indication for determining the MSI status of this patient. Because in truth, and when we think about first-line systemic therapy of this patient, it will either be oxaliplatin or irinotecan-based chemotherapy in combination with either one of the two biologic agents, the anti-VEGF antibody bevacizumab, or in combination with the anti-EGFR antibody cetuximab or panitumumab if the patient's tumor has wild-type RAS. I think where we would consider MSI testing would be in the disease refractory setting. So we now know that based on, I think, really impressive results, small numbers, but very impressive results published by the Hopkins group, that in patients who have metastatic colorectal cancer whose tumors are MSI high, have evidence for microsatellite instability, they will actually have upwards of 30–40% response rate to the anti-PD-1 antibody pembrolizumab. Also, I think there now is data supporting the use of the other anti-PD-1 antibody, nivolumab, in patients who have MSI high disease. So I think in kind of the disease refractory setting, the MSI status is quite important. I think where actually the field is now heading is, unfortunately, the number or percent of patients with MSI high disease is relatively small, on the order of perhaps 10 to 15%. So the vast majority of our patients with metastatic colorectal cancer have what's called MSS disease, microsatellite stable disease. And I think where many folks are going, including our own here at Pittsburgh, are trying to see whether or not we might be able to employ a strategy where we're combining different immunotherapies or combining immunotherapy with targeted therapy. And perhaps the best example is this very interesting study that is being conducted using a MEK inhibitor, cobimetinib, in combination with the anti-PD-L1 molecule atezolizumab. And those results have been very impressive in patients with MSS metastatic colorectal cancer, where the overall response rate's on the order of 30 to 35%. With respect to determining which test is easiest to perform, I think a lot really will depend upon what the capabilities are of the individual laboratory. And I think, truthfully, either MSI testing or testing of the MMR genes, either one really can get us the same answer. And if, in fact, there's presence of MSI high or presence of mutations in either one of the mismatch repair genes, we have our answer that, in fact, that patient has HNPCC or Lynch syndrome. With respect to testing, either MSI testing or mutational analysis of the mismatch repair genes can be done. The other point to note is that now there's actually a very high association, in fact, close to 100%, between IHC expression of the mismatch repair proteins and MMR mutational events or MSI high status.